because of time limits, we have to go start it. We are very grateful to have the opportunity get this kind of virtual meeting. So we have a great panel. Let me introduce one by one. Dr. Lee, this is the current Taiwan Society of Cardiovascular Intervention chairman, and Dr. Chih-Hung also the previous one, that's ex-president of the TSCI, and Dr. Lu from BGH Taipei. He's the general secretary for the TSCI, also the expert of intervention. And we have a great speaker here. Tonight we have Dr. Lee from Cheng-Han Lee University in Hainan, and Dr. Lai from VGH Taichung, and Dr. Tong. He's actually my students, now working in a previous affiliate to the Chang'an Memorial, Kaohsiung Guangyao Hospital. And Gábor from Hungary, welcome. Good afternoon, right? Okay, we have 6 hours difference, time difference. So, and Dr. Zhai, actually, he is working in the Meng-Shen Hospital, the two biggest hospital PCI volume in the world. One is Meng-Shen Hospital in Beijing, and one is Guangyao Hospital. So we have hopefully tonight we have a great discussion regarding the APT new products, tapered expressments. So for time's sake, I'd like to give my chairhood to Dr. Chih-Hung to introduce the first speaker, Li Cheng-Han. So Dr. Chih, please. Chih-Hung.
Yeah, okay. Okay, good evening, everybody. And today it's my great honor to introduce our first speaker, and Dr. Li Cheng-Han from National Cheng-Kung University Hospital. And Dr. Li was graduated from the National Taiwan University, and currently he is the director of the cardiac catheterization lab of National Cheng-Kung University Hospital. And he is also the associate professor of the Department of Internal Medicine, College of Medicine of National Cheng-Kung University. And as we know, Dr. Li is an expert of the complex PCI. So today it's our great honor to invite him to give us the first speech. The title is the application of extension catheter with side holes in complex PCI. So let's give a warm welcome to Dr. Li Cheng-Han, please.
Okay, can you hear me?
Yes.
Yes.
Yeah, that's good.
It's my great honor to present my today's topic, the application of extension catheter with side holes in complex PCI. You can see this case. The patient has some mild CAD of the LAD and circumflex, but the RCA is total occlusion at the middle part. And you also see a very tight lesion at the proximal part. And the patient received no collateral flow from the left side. So if we canalize on the right RCA, and sometimes we need deep engage of the vessel, even we need the extension catheter. In such situation, if we have the side hole catheter of the extension, maybe we can do more safety for this patient. And sorry. And another situation is like of this patient, the vessel is tortuous and calcified, and the lesion from the proximal to the distal part. And when we do the balloon dilatation, and then we need to deliver the stent, we may meet some very difficult situation. So the deep engage of the extension catheter is necessary in situation. And if the extension catheter has the side hole, and we can also very gently, and we can safely finish the patient. And let me introduce the guide extension catheter. There is several kinds of the guide extension catheter. Usually you can see the extension catheter have better design and then before, and you can use the overload wire and put the balloon and the other device into the extension catheter. And right now we have several kinds of the extension catheter, including guide liner, telescope, and Gaziza. And also recently we have the APT Expressman microcatheter. And the Expressman guiding extension catheter have some designs for compressed PCI. It usually has the special design, including the 35 centimeter guide segment. And you also design as the hydrophilic coating, and there's the 90-node shaft. So when we push this kind of the extension catheter, it have more support and can deliver the extension catheter more deeply. And it also has the another design is very different from the others. I think this is a unique design. There is the 4 side holes at the ends of the extension catheter near the 2.5 centimeter and the 4.5 centimeter. So if we do the deeply engage the vessel, maybe provide some flow through the side hole into the distal part, and maybe cause less ischemic time for the patient. And I will introduce some case to you to see what's the advantage of this kind of the extension catheter. This is the 71-year-old man. He has the ESRD under hemodialysis and diabetes and hypertension, hyperlipidemia. The patient have the history of the lung STEMI and CAD triple vessel disease post PCI for the LAD. And last November, the patient also has another episode of the small lung STEMI, and also has the intermittent junctional reason. The ejection fraction was about 42%. You can see the right coronary artery is relatively okay, and the left coronary artery is also, the LAD is also good. But you can see the distal circ is total occluded. So we use the strong support of the guiding catheter EVU 3.7577 French, and we use the Gaia first and then Gaia second. And when we advance the Sapphire 1.0 balloon, but the balloon was stuck near the middle part of the circumflex, cannot advance through the distal CTO segment. So we use the Expressman and 6 French extension catheter. I want to test the side hole and the no side hole extension catheter to see if there is any difference. So you see, I first use the anchor balloon and advance the no side hole Expressman extension catheter to the middle part. And you can see when we use the no side hole, the pressure is damped, and the blood pressure was about 60. And then I changed to the 6 French side holes Expressman. You can see the pressure is good. So if you do this kind of the PCI, you can slowly and safely and to deal with this kind of the lesion. And finally, you can see we got the better distal flow. So this is I just want to prove the side hole extension catheter really have some advantage in this situation. And I also provide another case. Is the 76-year-old man, smoker, hypertension, hyperlipidemia. The patient present unstable angina this time, and the angio show the triple vessel disease. The LV ejection fraction is adequate. You can see the right coronary artery is a very tortuous from the proximal to the distal part, and calcified and tight region, especially in this AP view. And the left side also has a very tight region at the proximal LAD, and circumflex also has the diffuse stenosis. So after we finish the LAD lesion, there's no problem. However, when we deal with the right coronary artery intervention, I use the SAL 7 French side hole because there is some lesion at the orifice. And initially, I used the body wire technique to advance the NC balloon to the middle to distal part, and high pressure balloon because the lesion is tight. I need to do the well preparation, and then I can deliver the stent smoothly. However, the stent cannot go through the middle part of the RCA, so I use the Expressman 7 French extension catheter, side hole or no side hole, to test the advantage of the side hole. Firstly, I use the anchor balloon and advance the no side hole Expressman extension catheter, and you can see if I use the no side hole extension catheter, the pressure is also damped. And if I change to the side hole Expressman catheter, the pressure is better. So after use the extension catheter, the long stent can advance to the lesion, and I can do very safely, and finally the result is good. And I also provide another the case of the situation. This is the 78-year-old, and the patient have the CKD, hypertension, hyperlipidemia, and the patient present the heart failure with lung edema. The ejection fraction is not good, about below 40%. And the patient also has the non-STEMI. You can see the right coronary artery. There is some lesion at the middle part and the distal part. And the left side, you can see there's the tight lesion at the lemon and the calcified LAD diffuse. And another view, you can see this is the bifurcation lemon disease, and also very severe and circumflex lesion. Because the patient is very old and some comorbid disease, so the patient received the PCI. And the right coronary artery is done very smoothly without difficulty. And when we do the left side, I use the strong support guiding catheter. However, the lesion is very tight, so the balloon cannot go through the middle to distal part. I use the Expressman and 6 French side hole. In this patient, I don't use the no side hole initially, then change to the side hole. Because I have some experience of the side hole and no side hole experience. So this time I directly use the Expressman side hole catheter. And during the procedure, there is no pressure damping during the deep engaged. So in this kind of situation, I also use the IABP support for this patient due to severe lemon and bifurcation, triple vessel disease, and decreased LV dysfunction. And finally, the patient can use this kind of the side hole Expressman catheter smoothly. and without complication. And I can do the high pressure ballooning and then the long stent delivering in this patient. And finally, the patient has very good angio result. So this is my take-home message. The guide extension catheter really plays a good role in complex PCI, such as the tortuous lesion, calcified region, even the CTO intervention. If we meet the situations like this, or even very bad LV dysfunction, we need to engage of the extension catheter. The extension catheter with the side hole could provide very good adequate distal perfusion, even deeply engaged during PCI, and it provides us enough time to deal with the complex lesion and deal safely this kind of the lesion. Thank you.
Thank you.
So thank you very much for Dr. Lee's very nice presentation. So Dr. Wu, can we have some question for discussion, or we should go ahead of the next speech? Dr. Wu?
Li Wenning is available. I can see that Dr. Lee, because 3 cases for Dr. Li Cheng-Han is very complex, also very calcified. For the lesion preparation, because we don't see the imaging, especially OCT or maybe the imaging. So I know that Dr. Lee is very aggressive to do a lesion preparation. But however, I think that current indication probably imaging guidance would be a better, and also barking, or maybe in Europe, maybe you have a shockwave, you have a rotabrator. So this kind of barking, is that necessary to get even a better result, combination with expressments?
I think it's very important. Sometimes we need to use the extension catheter to assist rotar ablation for the patient, especially the distal part, the distal part PCI. And if we could use this kind of the side hole device, maybe you can have enough time to deal with such kinds of the tight lesion and provide better hemodynamic support for the patient. And if usually when we do this kind of the difficult situation, if the patient have the ischemic chest pain or the unstable blood pressure, and we cannot do very safely, and even we cannot do very perfect for this kind of the situation. So I think next time when you meet this kind of the situation, you can try the extension catheter with side hole.
But for the IVUS, the question is, the tapered tip expressman with side hole, is it difficult for even putting an IVUS? I guess the OCT should be fine.
If we want to use the IVUS, we need to use the 7 French or 6 French, or 7 French guide extension catheter. And I have tried use the 5.5 French of the guideliner. It's impossible to deliver the IVUS into the guideline 5.5 French.
Okay.
Dr. Tong would like to comment here. Basically, the 6 French Expressman guiding catheter is compatible with IVUS catheter, because I basically use it quite a lot.
Yes.
Cheng-Han, this is Dr. Yi Zhangxue speaking. Can I have a question for you?
Yes.
This question regarding, do you have any idea regarding the size of the side hole? I mean how big of the side hole. That's similar to the side hole of the regular guiding catheter, or bigger or not, or smaller. Do you have an idea?
I think it's similar as the guiding catheter.
Okay, I see. Thank you.
Welcome.
Any other questions? Or
Yes.
we have to proceed to the second topic. Any other question? Dr. Lai, you have any comment or questions?
Yes, I think in my next talk, I will talk about something about use tapered guiding catheter in image device. So, but lots of time I use the OCT, so I only show the OCT data. Okay.
Okay. So, Dr. Xu, if no further question, maybe we can just go proceed. Let the Dr. Lee, current president of PSCI, Dr. Lee, to introduce Lai Chih-Hung. Is that okay?
Okay, thank you very much, Dr. Wu. Our second speaker, Dr. Chih-Hung Lai, in actually is a staff of Taichung Veteran General Hospital Cardiology. He's not only a very experienced interventional cardiologist, but he also is versatile cardiologist with diverse subspecialties. He's not doing complex coronary interventions, but he's also experts on non-interventional cardiologists like hypertrophic cardiomyopathy, Fabry disease, and interstitial lung disease. He also has interest in genetic study of the cardiology diseases. I'm glad to introduce him tonight to deliver his speech. His topic is entitled "The Expressman Guiding Catheter." Its features and difference from other guided extension catheters, and also some interesting case sharing. Dr. Lai, please.
Thank you. Very kind introductions. My talk is about the extensions Expressman guiding catheter. First, I will talk about something about the extension guiding catheters. Lots of times we need the extension guiding because we facing more and more complex intervention, especially with some vessel with calcification and very tortuosity. And that's make us very hard to deliver any intervention device. So lots of times the factor lead to fail equipment delivery, including the poor backup support, poor axis alignment, increasing tortuosity of target vessels. So there are several ways we can deal with to increase our support. You can use passive techniques. That means that you can change the guiding catheter to a bigger one, or change it to more support guiding catheters. But lots of time we use more active techniques, including we don't need to change your guiding catheter. We just deep seat in it, or use balloon anchoring, or use micro catheter include support. And lots of time we use extended guiding catheter. The extension guiding catheter is almost 18 to 20% in our daily interventions, especially we're dealing with very complex regions. And extension guiding is including the overall wire device. That means there's heart trails, the daughter in mother's guiding catheter. But lots of time we use repeat exchanges extending guiding catheter, such as Guangyao, Expressman, GEC. So this is a list of what we can have from extending guiding catheter. Those times we want to increase our support and also good alignments for our interventions. And then that's for we can deliver our device across a very calcified, very tortuous vessels. But sometimes it's really extensive over guiding catheter. So we can extend in our guiding to approach such as anomalous coronary original or some graft intervention, or cross the TAVI's stent stroke into the coronaries. And also we can use the reverse cut technique. And they also have other functions such as distal drug delivery, thromboaspiration, or you can just extend in your guiding catheter into more proximal vessel to do the selection angiography. And sometimes we retrieve some traveling equipment such as rotor or balloon. So this table shows currently approvals in America's the older guiding catheter, which introduced by Dr. Lee previously. They are very similar, including guideliners, Garziza, triple line, or 12 scores. They have very similar, such as they have a very similar length and very similar the guidance sections. They are always 25 centimeters, and the interdiameters is also very similar. It's almost 0.56 inches. So they are also this 6-French compatible guiding extension guiding catheter. They are very similar in general design. And this is the expressments we want to introduce, and also be introduced by Dr. Lee. They have a 90 longs the pushes wire. They have a colors design, and especially the distal side hole design, so macular pressures not dampens, and you can detect distal pressures. They also have a much longer the guide segment. The guide segment is 35, which is normal than usual 25 centimeters guiding support. So they have also they have a mesh braid layer, so keep the guiding segments more stronger than coil-like. And they have a color design, which is right now is very always used such a guide that use a similar design. This is compared with other extension guiding catheter, including the Expressman, Garzila's, Telescope, and Guangyao. You can see that if they are 6-French guiding catheter compatible, they have a very similar inner diameter, outer diameter. The difference about the Expressman is the extension's length is much longer, is 75 centimeter. They have a distal pair side hole to have a distal perfusion. So the longest segments can have a much better support. They can bypass the tortuous vessel. And so when you push the stand, they will not very hard to push that. They can very smooth across the collar side. Also, they have a distal side hole, which was introduced by Dr. Lee. Is very good. You can detect the distal perfusions and also have antegrade perfusion. And let's see, we have general. We have a 6-French guiding catheter compatible Expressman or 7-French guiding catheter compatible. In the 6-French guiding catheter compatible Expressman, the balloon loss we can use a less than 5 millimeter. The stand can less than 3.5 millimeter stand. And they can cross the volcano's eyebars or optical eyebars. But I have to say I use optimal curves, but I don't use a volcano before. This is a list or advantages benefit of a unique design, including distal side hole can have show our distal perfusion, have a good pressure detection. They have a 35 centimeter guiding catheter, so they can cross the tortuous vessels, have more smooth delivery. The taper collars can have a good match, smooth transitions. But just mentioned by our moderators, they have a special some tapers designs. This is lots of the 6-French guiding catheter compatible Expressman. They have 5-French outer diameter, but this is taper design. They have a 10 centimeter, much smaller distal tip. They are around the 4-French outer diameter. So let's taper from 5 to 4 in the distal 10 centimeter. So therefore, they have a better, they can have a more advanced to the more distal segments. And the very smaller distal tip can eliminate the gate between our guide wire and the extension guiding catheter to make our delivery much more smooth. So this taper one, they have a distal 4-French outer diameter. The inner diameter is only 0.05 inch, is around 1.27 millimeter in the diameter. So therefore, it's much smaller, even smaller than the Guangyao 5.5 compatible guiding catheter. So they have a balloon, they only can deliver less than 5 millimeter. The stance is much smaller than 5.3 millimeters. They can pass the IVAS, OCT, and opticals. So this is French guiding catheter compatible all the currently extension guiding catheter, APT, Guidelines, Telescope, and Gazeta. They are very similar inner diameter and outer diameter. But when it comes to tapers one, you can see the distal taper one is much smaller inner diameter, only 2.27 millimeter diameter. It's a little bit smaller than Guideline 5.5 French, the extension guiding catheter. So in our cath labs, we have this spatial taper guiding catheter just last October. So only till now around 5 months the duration we use that. We have experienced about 26. This is spatial taper guiding catheter we have to use. The device successful around 97, 96. One failed due to final that we have to do rotor ablations. So this is growing popular use in our cath lab. I want to show some case show this spatial tapers guiding catheter, extension guiding catheter. This is a case with a tortuous circumflex artery. The distal side is very high to take off in the proximal circumflex. This is another view. You can see the spiders, very high takeoff proximal circumflex and then going down. So the delivery stent is not so hard. You can deliver 2.5 millimeter stent very successfully, but you want to do the post dilation, you find it's a little bit hard to push the balloon across the stent stroke. So in this moment, we have several techniques that can help out. We can deliver it, such as we can use trapping balloon technique and push your extending guiding catheter across the lesion. And we also use a balloon assistant tracking device. You put the balloons out over your extension guiding catheter a little bit, and the infrared and the defrared, and make the guiding catheter can track the balloon into the lesion or the stent. So we use the same technique, use Expressman taper guiding catheter. When we push the balloon just in front the stent, and we inflate it a little bit, then deflate it. And you can see the Expressman taper guiding catheter can into the stent very smoothly. So you can do all the post dilation as you use. Same condition, we use a 2.75 NC balloon. Same technique can well deliver this balloon. This is final angiography, show very well sustained expansions. Another case we want to show when we deal with very distal RCA lesion, spatial PDA PL lesions, we need to do deep intubation. This is typical PDA distal tortuosity and diffuse lesion. So it's not hard to deliver a stent, especially you deliver even a long stent. But when you do the post dilation, you find this not good enough. You want to do the post dilation. But you find seeing the NC balloon still very hard to cross the stent, especially very distal and very tortuously even after standing. So we use four tapers Expressman guiding catheter. We might see you can push as the guiding catheter can be a very deep intubation even to the PDA stent very smoothly. So just like Dr. Lee mentions, even you have this seating, the distal side hole can make you sure the distal pressure is not damping so much, keep the antiquate perfusions. So this is the final angiography balloon dilation. So similar condition in the PLO distal lesion. This is not well prepared distal bifurcation lesion. You can see the PL and the distal have Medina's 111 lesions. Also a little bit smaller PDA, but the PLO is still very severe disease. So we do the balloon dilation smoothly, but very severe recoil over PL lesions. So it makes it very difficult to deliver a stent. So we use tapers Expressman guiding catheter, extension guiding catheter. You can see we can advance is very distal to almost a PL. And so we can make the PL stent deliver very smoothly. Even the lesion is not prepared very well. We'll do the finals and the post dilation. This is final angiography, shows very good stent expansion. Final one, I want to show more complex lesions. This is a circumflex calcified lesions. We need to do a low type ablation, also the LCT examination. These patients have already have LD low type ablation after put a long stent from the LD distal to low stent. This time we try to do the circumflex intervention because previous failed balloon dilations. You might see circumflex middle to distal is a diffuse calcification and the tortuosity vessel. So this is circumflex. It's look not so calcified, but it's really failed to balloon dilation previously. And after wirings, it's very difficult to advance microcatheter corset. This is a fine course microcatheter. It's very hard. So we try to do the balloon dilations. We use a guiding catheter, extension guiding catheter support, but the Sophia 1-point balloons cannot cross it, even causing the balloon ruptures. So it's very tight lesions. So in order to avoid the bare rotor wirings, we try to use a manual tunnel lining with Turnpike-Go's turning device. So this is Turnpike-Go with the support of a Ziza's 6-French extension guiding catheter. You can see the 6-French guiding catheter cannot advance as much as tapered expressments. But we try to get because this Turnpike-Go is a little bit bigger. So we use 6-French Ziza guiding extension guiding catheter. But Turnpike-Go cannot cross the lesion successfully, even a little bit more advancing. So finally, we do the bare wirings to cross a critical lesion. This is a rotor wire bare wiring. After we use 1.25 millimeter rotor burr to do that. Finally, it's crossed. So after that, we do the OCT examination under the Expressman. This is Expressman support. We use a balloon dilation. The first is a 2.5 millimeter balloon. This is a 2O NC balloon. After that, we use Expressman taper support to deliver OCT. This is an OCT device. You can see we need this is kind of extension guiding catheter to support the cross tortuous vessels and also the beta support. After crossing that, we put this tapered Expressman guiding catheter, the tip around the Austin of a circumflex to do the selections to control the injection to do much better images of OCT. This is what we do. We do a little bit selections to do a much better controls washout of circumflex. This is OCT qualities. After we do the selections, the tapered Expressman injection, you can see the image is quite very well. There's no blood inside there, so the flush is very good. This is not by the power injection. This is by hand push the contrast. So there really is a severe calcification around here. It's very calcified regions over here. So the rotation definitely needed in this kind of case. So after we put a stent, after stent, you need to check the OCT again. So use Expressman to do the OCT again. You can even under the support can close the stent very well. And in the same ways, push the Expressman in the Austin of circumflex to do the selections contrast injection and pull back the OCT. This is final angels, very good OCT quality images. You can see the full stent expansion, and this is final angiography. Ladies and gentlemen, these are my take-home messages. The advantages part of Expressman extension guiding catheter, just like previous mentioned, they have a unique side hole, which you can do the deep seating, keep antigrade 4, and the pressure detection. They have a much longer guide segment, have a much better support, smooth transitions. The taper part is a spacious design of this kind of extension guided catheter. They have a much safer advance in beta support, beta smooth transition, and compatible with images, intravascular image device, which all the mentions were well adapted in complex PCI lesion. Thank you for your attention.
Thank you very much, Dr. Lai, for your wonderful presentation. When I'm watching your presentation, also the presentation by Dr. Lee, it reminds me in the my experiences in the cath lab. And I just yesterday, when I did the cases with our young fellows, I just chat with them and telling them the story of core intervention back in the old days. I think Dr. Wu, Dr. Xie, and also have the same feelings that with the improvement in the techniques and this gadgets and these advancement of these new devices that really make the core interventions an easier job. Back in old days, we have to use the very big guide catheter like the 8-inch AL guide for the right core interventions. I think now Dr. Wu and me also have the same stories. Then even with these very big guide catheters, we cannot advance the stents into the coronary bodies. So even with the new devices, and especially with the improvement of the devices like the Expressman taper extension catheters, now make our intervention life more easier. I think that these two lectures are really convincing. And also I thank Dr. Lai for sharing his 4 interesting cases which are showing us very convincing and showing the 4 case scenarios that we have to use the Expressman, especially taper ones, for very tough interventions. I think these cases are very convincing. I like them very much. I think that everybody, I think that perhaps not everybody, I think most of us have the same feelings that these the tapered Expressman are making our life much more easier. Is there any questions from the audience or the fellows to have for Dr. Lai?
May I ask a question? Because
sure.
OCT is beautiful, but you know, Dr. Lee, our supervisor, Dr. Lee, is very aggressive to debarking. This case is 1.25 millimeter burr. Not firing by the cutting or maybe very one-to-one high pressure balloon dilatation. Although the final stent is good expansion, but right now if we do a dedicated job, we'd like to see after debarking OCT, maybe you do some further lesion prepare, and after stenting, and you have a very good expansion to achieve the best result to prevent future restenosis. What about this?
Yes, thank you. And that's we do the 1.25 millimeter burrs. Actually, we want to do much more enlarges as debarking technique is right, but because we are not sure overlay about distal wire is very tortuous. So actually, when we do a rotablation distal side, we find that the burrs cannot cross very smoothly. But we think it is caused by the very tortuous or distal vessel. So we don't upgrade our burr because I think there's very high chance we might transition the rotor wire. So that's why we don't upgrade the burr. Actually, we want to do that, but we think this is very risky. After last, indeed, we can do such like the cutting balloon to get a more better lesion prepare. But after the NC balloon dilation, we see it's much good enough. So that's why we don't do that. Yes, but actually, just like saying, if we can allow that, well prepared is much better, indeed.
Thank you.
Any other question?
And Dr. Lai, I have a question for you. And do you have ever experienced when you use the taper Expressman catheter, you still have some situation that when you deep engaged and you meet the pressure damping during the procedure? Do you have ever experienced?
Yes, I still have that. Yes, I still have that. If you really dipped into base, actually it's a pressure dampen, but it's not as much as the biggest one. I think so. Yeah. But indeed, such as the right quadrant, you put it very, very far distal, actually let's still some dampen. But it's not much as we use 6 French's regular extension guiding catheter. Yes.
Yes. Yes. So maybe you can, if you have a situation like this, I will suggest you next time you can try the side hole expressment. Maybe it will do the procedure more safely.
Yes, actually I use a side hole one. The taper one still have a side hole.
Okay. Okay.
Yeah, indeed. But when you very distal, they still have some pressure dampen. It's not as perfect as proximal side. They still have some.
Mm-hmm.
Any more question? Gábor, are you interested to raise a question? From
I'm just listening, and it's very interesting and very nice presentations. So I'm here.
Okay. Okay. Thank you very much. Now we're going to pass presentation to the next one. I'm not sure who is the moderator for Dr. Tong. Okay, Dr. Lu, please.
Yes, thank you very much. And I would like to introduce the next speaker, Dr. Meng-Shen Tong. He's a graduate from the Kaohsiung Medical Center and received well training in Kaohsiung Chang'e Memorial Hospital. And I think he's also a student of the Master Wu. And I think today he would like to deliver the speech entitled of the application of the expressman for the long calcified lesion. I think is again a similar topic, but I think his case will be more complex because I think as the panelists has mentioned about the lesion preparation is very, very important, and I think although the extension catheter can deliver the stent or device more distally, but it is not always not a substitute of a good preparation of the vessel. So I think maybe Dr. Tong will bring some very, very interesting and complex case for us. Dr. Tong, please.
Okay, good afternoon to Dr. Gábor and good evening to fellow friends here in Taiwan. Today I would like to share a case where I'm using the tapered expressman. In this case, tapered means 6 French tapered into the 5 in a case with extremely tortuous and calcified vessel. Okay. And this is a 7 years old man with medical history of hypertension. He is a non-smoker and was presented to our emergency room with orthopnea and a hunger. So this guy is intubated in our ER and non-STEMI was impressed. So you can see here the X-ray here. This is taken last year in January, whereby you can see some cardiomegaly, but the lung seem some fibrosis over the left side. But this time, this year taken in January, this presentation obviously got a very severe pulmonary edema. So the ECG, of course, is basically a sinus tachycardia with a CLBB pattern. So it's as I do a bedside echogram for him and got a poor ejection fraction around 34, and basically the anterior rectal and apical is hypokinesia. So what I do is this is the summary of my PCR worksheet. I'm using a 6 French Chimie mini guiding catheter for diagnosis, and then shifted to 7 French EBO4 for left side and the right side with the M+ short tip 1.0. Workhorse wise, I just use a usual 0.04 of 1.1 through and an Asahi filter XTA. So the supporting devices, this is the APT Expressman 6 French taper into 5. So this man had a renal function is a little bit bad with so I got a limited contrast use for this patient. So this is the AB coder. You can see here the circumflex had a very tortuous and calcified from the proximal mid to distal part. And the LAD, you can see the LAD here, the proximal and mid. This is quite simple, but still very calcified. And distally, we have collaterals from the apical to RCA. From the spider view, you can see the SIR here is nearly a U-turn, U-looping calcified and tortuous vessel. And the RCA is the omega light is almost a 330 turning, hairpin turning with a calcified and tight stenosis at mid segment here. So this is the trouble. And of course, the distally, you can see here, sorry. And distally, we have some, the competing flow from LAD as well. So my plan, because the patient's clinical condition is quite severe, so I've got a careful decision making with the family. Of course, bypass is the best for him, but rejected by family, and they preferred the PCI. So we can expect some high complexity of the coronary vessel, and because of the calcified and tortuous, and poor support is to be expected. So I might use an extra support guiding catheter, including the guiding extension catheter as well. Rotablation might not be an option because of the vessel is too tortuous. So might face more problem well, if I face some dissection as well, also failure. So, and for this case, I can only use 4 stents because because of our national health insurance policy, I can only put 4 stents, and the patients have some financial difficulty to afford more stents. So this is a very troubled decision making for me. So my plan is to change. I just changed the backup with 7 French, and of course, if I can do a total revascularization, then it's the best for him. But at least I can do the left side. As I said, rotational atherectomy is not an option because the RC is too tortuous for him. So I try to do the left side first, then only consider RC. It depends on the procedure time and the contrast I use. So I plan to just deploy 1 stent to LAD and 2 stents for RCA. So I think LAD is not a problem because it's just calcified, and you can see the balloon here can cross the lesion quite smoothly. So we have some dissection at the mid segment, but passing stent is not as difficult as we thought. Okay, so but the stent here is a little bit short, but I have no choice but to deploy from just from proximal to the mid part. Then I post dilate with another NC up to 20 bar. The result seems fine, and you can see better flow to the distal collector to RCA. So then I came to the SIR. So the SIR was crossed with the XTA wire. Dilatation wise is with the Euphora 2.0 and 3.0 balloon, it seems fine. So with the balloon here anchored, you can see the taper expressman tip can pass all through from the proximal to mid-segment quite smooth. Yes, you have no resistance, can see here. So this is another 30 by 30 millimeter bimetal stand deployed at mid segment. So actually should put further, but I need another extra stand. So I just put one stand for this side. So this picture gives us for this kind of patient, the post I need quite exactly post dilate because if I pass through the stents, might cause some dissection. It cause me another stent. So with the help of the expressman, they give me very good and precise positioning for post dilatation with the NC balloon. So this is the final. Of course, the mid-distal part a little bit hazy, and I should put another stent for this patient. But to my experience, the tapered expressman, if you really need another stent, you can pass through the stent strike quite smoothly. So this is the RCA. RCA, from the picture on the left side, you can see this is almost 360 turning and tight stenosis at the mid RCA with bifurcation at PDPL as well. So this is the lateral view, almost 90 degrees stenosis at mid RCA. So after wiring, I just changed the guiding catheter to a 7 French Medtronic short arm plus. Body wire with run-through and filtered XTA. So I just pre-dilate the PLPD with a small U4 1.5 and 2.0 balloon. So this is the first angio after I dilate the PLPD. So with the extra support of the expressman, the tapered expressman tip, you can see here I can push the conqueror, the semi-compliant conqueror balloon to cross this hairpin or omega light lesion. I don't know. So, however, the popping at the mid RCA I can't achieve with the semi-compliance balloon. So later on I will show you how I do with the mid RCA. So these three pictures shows the furthest tip I can go almost to almost past this 360 turning here, but still I feel great resistance when pushing the balloon. So for this lesion, you can imagine I might use several new balloons to cross this kind of lesion. So this is the furthest tip I can go. So I try to deliver another 30 by 30 bimetal stent, but no matter how deep I sit, I have anchored several times. This is the furthest tapered can go, but my stent, because of the design of the stent, I can't cross to the whole this turning point here to the mid RCA. I just can't pass because of the very high resistance. So this is my desired side, but I just can't pass the stent to here. And possible because of the dissection of the mid RCA as well. So I have no choice but to deploy the stent as this part. So I will put another shorter stent here for proximal RCA. This is the shorter 30 by 15. So this is the NC balloon, as I said here. This is a balloon. The NC balloon I inflated almost up to 20 bar, but I just dare not to go harder, because if perforation happen to this area, I don't think I can manage to stop the bleeding. Even I don't think I can pass any cover stent to this side. So I just stop here. So this is the final angio of our CA. You can see we have much improved the flow at PD, although mild competing flow you still can see from here. So the mid RCA, you still have some very short linear dissection here. So this APD tapered expressman, of course, provide very good support and unimaginary possibility. It got good profile and compatible with 4.0 stent, and this is exceed the recommendation by the supplier. And this also 4.5 NC balloon compatible. And this is another case of not this patient. So save time and make less trouble for me. Thank you.
Thanks, Dr. Tong's very interesting case. One extremely tortuous vessel with a heavy calcification, and I think in this case there are many limitations from the financial limitation or insurance coverage limitation. So you have to put, I think it's a bare metal stent to cover to treat these very complicated cases. I think maybe we have to make some compromise. So, but as for the very extremely omega shape RCA, actually, in my personal opinion, I will give up the idea of a presso stent, because I think even you put the stent as a very tortuous RCA, but sometimes the stent will later maybe stent fracture will happen, or even very high risk of instant restenosis, especially you put the bare metal stent. So if this is my case, maybe I will try just a POBA and give a very good chemistry flow, and that's okay. I don't know, maybe I may invite the comment of the Master Wu. If this is your case, how will you treat this gentleman?
I probably agree with Dr. Lu's suggestion. I also agree to give up the RCA, very tortuous, because too much difficult. Even we can see a tapered tip, a guide extension expressman can push that non-compliant balloon into that mid subtotal occlusion. However, we cannot achieve popping. So subsequent stenting will not be possible. And debarking for this lesion, even the shock wave balloon, I think we cannot push down to this part. Orbital hysterectomy, rotablate, I think Dr. Lee also agree with me. This is not a case for debarking. So I also agree we should give up. Maybe for this patient, we treat the LAD circumflex is good enough for the patient, and blending might be would be a good option. Yeah, I agree with Dr. Lu.
Yeah, thank you. But anyway, I think it shows.
Can I also have a comment?
Yes. Yes, Dr.
So
Lu.
first of all, congratulations to Dr. Lee. It's a really nice case, a nice presentation. But I feel that this is the kind of lesion which is seriously overstretching our borders. So as far as I'm concerned, in my country, in Europe, most probably we would send this patient for the heart team discussion, as you did. And once the patient just refused coronary surgery, I think we would have only treated LAD, because this RCA with the double band looked super crazy. So you were really achieved a really nice result, but I think it's really overstretching our borders.
Yes. Yes. Thank you very much. I think this is actually is a cabbage case. But anyway, this case, I think the Dr. Tong has showed the beauty of the guiding catheter without the aid of the guiding catheter, extension catheter. I think this is impossible to complete the procedure.
Dr. Lee, any crazy recommendation for this crazy case?
You know, after your comment, I have nothing to say except I quite agree that given the loop-like right coronary arteries, and it's not wise enough to treat RCA, given that once the vessel dissected, you have no way to put in the stent to cover the lesion. Also putting in the stent with the residual stenosis more than 50%, I think the risk of the restenosis should be very, very high, and the long-term outcome is not good. And secondly, perhaps my view is different from yours. My point is when I doing the coronary intervention, I like to preserve every important side branches, like the diagonal case. In this very case, it is very big and very dominant. I definitely did my every effort to preserve the diagonal branch. However, in this case, the operator actually lost the first diagonal branch after the stenting. And I think that would make life not as satisfactory as possible. So perhaps people, different cardiologists have different views, but my point is to try to preserve every important side branches like this one.
Yes.
I totally agree with Dr. Lee. Because of this case, it got a very quite calcified lesion, so I did not put much effort on saving the diagonal branch.
Dr. Tong,
Yes.
can we see the final angle of the LAD again?
All right, hold on. So this is the initial angel.
Yes.
This is the initial angel and the final. Sorry, this is not the final. Yes.
Oh.
Diagonal here is angel.
It looks like the big diagonal branch has disappeared, right? So I think that this diagonal branch is very, very large. So I agree with the Chief Lee's opinion that maybe we can try, we should try our effort to protect the diagonal branch. But before you stand in, maybe we have to use a small balloon to open the orifice of the diagonal branch.
I agree.
So Dr. Lu, we would do a chair balloon technique, or you just put small balloon dilatation before stenting, or just wire protection at least.
Maybe I will try a 2.0 balloon or 1.5 balloon to open the orifice of the diagonal branch.
Okay. Could I just speak for myself? Could I speak for myself? Because given that the bifurcation is heavy calcified, I think there's no way to preserve the side branch except the rotor ablation ad hoc.
Yes, I agree. But because I think this financial limitation of this case, right? Yeah, yes. You cannot force the rotor operation.
Okay, so with time limits, we have to go proceed. Next
Yes.
speaker will be invited to our international guest, Gábor Dékány from Hungary, to share us that LAD PCI impossible without a guide extension. Gábor, please.
Yes. So, dear colleagues, thank you very much for the invitation. I'm really honored. And I'm just trying to share my screen,
yeah.
but it says that, yeah,
All right.
now I try it again. Okay, so sorry for this, it was my fault, and really honored for this invitation. I'm Gábor Dékány, interventional cardiologist from Budapest, Hungary. So I don't know how do you, dear colleagues, feel, but as far as we experiencing by the aging of the population who we treat, it's more often quite common that we meet with quite complex PCIs, and I just try to collect a few reasons when we have to use advanced devices in order to have success in the field of coronaries. I think why do we have to use the guide catheters? Guide extension catheters is either very heavy calcification or very severe tortuosity, or maybe we are experiencing difficulties to go through previous stents, or we are experiencing really hard device delivery, for instance, when we are facing with CTOs. And also one more reason, if we are most commonly try to engage saphenous venosus graft, we sometimes need to use guide extension in order to be reaching guide positions. So I think we have heard so many nice presentations and talk about the structure and the design of the guide catheter. So I don't think so I will waste much time with this. It is just a schematic picture how one should use the guide catheter. It should be used in conjunction with the guide catheter. And I feel as a general rule that the inner side of the guide catheter must accommodate the outer side of the extension catheter. So usually, as an average, almost all 6 French guide catheter can accommodate the available used guide extension catheters, since those are 5 French old. These pictures are from the EuroPCR educational website. Theoretically, there are 2 ways how one can advance with the extension catheter. To be very honest, I usually try to go down with the extension catheter on the wire, just very gentle, very smooth movement. And if I experiencing strong resistance, I try to use this balloon assist tracking technique, which means that we very gently push forward the balloon, inflate the balloon, push down the guide catheter until it goes smoothly, then deflate the balloon. And in the moment, once we are deflating the balloon, with a very gentle pull back of the balloon, we try to push the guide catheter and usually, the extension catheter, sorry, not the guide. And usually by these small and very gentle manipulations, we can push down the device until the desired position. I think design and structure has been discussed previously. Just again, let me emphasize the unique feature of the Expressman is just the side holes, which might make the procedure more safe without pressure dumping of the arteries. So now we are reaching the first case, which I would like to present you. And I would like just to highlight that we are a very high volume center, and those patients are not very highly selected patients. So those are just patients from our everyday routine, and all these cases which I would like to present you has happened just 2 to 3 weeks ago. So we won't see like super crazy anatomy as we've seen before. Just I would like to show you in our everyday practice how extension catheters may help us. So she's 66 years old, female with the usual risk factor. She has some hypertension, diabetes, obesity, COPD. She had her right coronary and LAD stented before. And in this March, she was presented with an extensive anterior myocardial infarction. Ejection fraction showed severely reduced LV function with anterior inferior akinesis, some mitral regurgitation. So I just performed, as a general, I worked from radial. So we did the radial angiography with the Tiger catheter. And we can see that LAD, just at the level of previous, the mid part of the previous stance is occluded. And not surprisingly, the right is proved to be CTO, since we are seeing really nice epicardial collaterals from the circ going to the right. So it's not surprising the right is a CTO. I knew I will face with a difficult case, so I choose an access support guide. It's EBU 3.5, my workhorse guide, and I took a workhorse wire, which I usually use in occluded vessels. It's a PT2 guide wire. And with this help of this guide wire, I was not able to cannulate distal RCA. I felt some resistance, but I was quite confident enough that the distal part of the wire is in the true lumen. And since I couldn't see any flow, what I did, I just did an inflation with a 2mm balloon. And afterwards, I was lucky enough that the wire was in the true lumen, and we could see that the distal RCA, distal LAD, there is an aneurysmatic part of the vessel, and there is a thrombotic lesion just at the distal part of the previous stent. And immediately after this lesion, there is the aneurysm at the vessel. So I have had a really tough time while I was trying to wire this vessel, but after trying 2 to 3 wires, eventually a Chih-Hung black wire found the true lumen included aneurysm, and I had a nice guide position, nice wire position, but still I was facing with long previous stents and aneurysm. I did a really nice pre-dilatation of the vessel. I pre-dilated the vessel several times with a 2mm balloon, but I was not able to push down a 2.5mm NC balloon. So what I did, I just take my balloon, the 2mm balloon, and with the help of the balloon, I deeply intubated LAD with the Expressman guiding catheter. And after intubating the vessel, I was able to push down a 2.5 DS. After this, another 2.5 DS was pushed down to cover the aneurysm. And finally, I placed the 3.5 by 22mm DS, just the proximal part of the LAD. And I did a proper post-dilatation of the entire segmented part, although I was aware that the distal stent will not cover the entire aneurysm, but I feel that final result is quite acceptable. And since the patient had 3-vessel disease, anterior myocardial infarction, our plan was to stop the procedure as it is, and I'm just showing you how it continued. It's based on our best routine. We just stopped the procedure with LAD PCI, and a few days back, we just brought back the patient to the cath lab. We did an FFR measurement on the circ, which is proved to be significant, and we just fixed the lesion of the circ with a 3.5 DS. And I think that final result is quite fine. And with the RCA CTO, actually, we are planning nothing unless the patient became really symptomatic, and she was discharged a few days later on. So let's see the second case. She's a mid-age gentleman. He was presented with inferior myocardial infarction. Echo showed good AV function with some inferior wall abnormality. I didn't show you the left side. I don't want to waste time with that, but the left system was very severely diffusely diseased, but nothing critical to treat. And what we could see, even without injection any contrast, that the RCA was extremely calcified. And to be honest, I had difficulty even to engage the vessel because of the critical orifice lesion. Although the culprit region was not the orifice, it was the mid part thrombotic occlusion. But at this point, I had to make an unusual decision, and I felt that fixing the orifice, and after going more aggressively, maybe deep intubate the vessel, even with the guide catheter itself or guide extension, I could proceed. So as the first step, I inflated the 4mm DS to the orifice. I was able to push down the wire quite nicely distal with the help of the stent balloon. And here comes where the procedure just started. We can see that I was able to push down a balloon just with the help of a very deeply intubated Expressman guide catheter. And what I would just like to emphasize in this case, that it's quite often happen in my practice, that if I knew that I'm going to face with very difficult device pushability, I would rather choose a non-access support guide like Judkins Wright and deeply intubate the vessel with the extension catheter. Although we all know that deep intubation with guide catheter are available options and one may choose it to push down devices, but I rather feel that guide extension catheters by their natural nature were designed for deep intubation and might be less aggressive than going with the guides. And one may ask that why I hadn't choose access support guide, but I felt that with a non-access support guide and with a very aggressive deep intubation with the extension catheter, we can achieve as well nice result. If you see the extension catheter just push down in at least to the mid RCA, and the balloon without any major resistance went through, and after ballooning the vessel, I could give some contrast. Usually it's not an issue to give, to see the vessel with in some very gentle contrast injection if a 5 French guide extension catheter is deep intubated, and we could see the culprit lesion in mid RCA before the crux. And what I have done, I just placed the 3 millimeter DS distally, followed by a 3.5 proximally, and I did a proper pre-dilatation with a 4.5 NC balloon just at the orifice. And this is what we could achieve with this RCA. Actually, it's a huge vessel giving a huge posterior-ventricular branch. So how I would summarize my case. I think guide extension catheters are not the devices for every PCI, but those are devices that must be on the shelf of each and every cath lab, and all independent operators must be aware how to use those devices, because by doing so, you may decrease the procedural time, the amount of X-ray, amount of contrast. On the other hand, you can save a lot of other devices, and it can dramatically increase your success rate in complex PCIs. Thank you very much.
Okay, thank you. Gábor, the speech is open for discussion. Any comment or questions? Oh, how long it's been available in CMARC, Hungary? The Expressman.
Can't tell you the exact answer, but I can tell you that this device is available in my cath lab since 6 to 7 months.
Oh, okay. So similar is in Taiwan here. How about in China? Because Expressman IPT companies, they made from that company from Hunan. So actually it was to get approval from CMARC. So should be more experience in China. Hey, Dr. Sai, any comment?
Hi. Actually, I have 2 questions for Dr. Dékány. Hello.
Yes.
So as for case 1, yeah, hello. As for case 1, I'm wondering. I'm not sure if I catch the whole point. The anterior wall is a culprit. Is that right? Because I'm wondering why you choose to do LAD first, because of the collaterals.
Have a look on the ECG. Have a look on the ECG.
Yeah, anterior. So I'm wondering, now that we are going to do all of the branches, LAD, LCX, and RCA, isn't it better to do the recipient of the collaterals? Is that a safer approach, or should we just do the do the LAD, the corporate vessel first? Just I'm wondering which one is a safer approach. This is my first question, and the second one is sometimes when as for the 2 cases we encounter with very heavily calcified lesions, if there's thrombus or if there's not thrombus, either way, I much prefer to do the pre-treatment first instead of just use balloons to inflate before any significant dissection are present, to exclude any use of further like rota or something. When there is like extensive, very much extensive thrombus, I would use like excimer laser or some other pre-treatment devices to, you know, to make the calcification more amenable to subsequent procedures. But because if we want to proceed with extensive inflation, if the significant dissection exists, there's nothing we can do if the stents cannot pass. And also we can find if the stenting is already happened, when the stent is not very well opposed, very well not expanded. So there's literally very little we can do to make the stent expand better, but also again use excimer laser to help the calcium underneath the stent to, you know, better amenable to later subsequent post dilation. So this is the two questions I'm wondering about. Thank you very much.
Thank you very much for your questions. So firstly, I think after the ECG and the angio picture, just LAD was the culprit. It was quite obvious. If you see the images of the right coronary, it's proximally occluded under a huge right ventricular branch, which is giving some homocoronal collaterals, but also from the circ, right is getting some collaterals. And regarding your second question, LAD was occluded in a stented segment. Unfortunately, with the laser, I cannot have any comment because this laser treatment is not available in my country. But I do agree that proper preparation of the lesion is extremely important before the stent deployment. But since it was previously stented vessel, I did not have much option. I mean, rotablate wouldn't have been an option because we don't like to rotablate. I know it's doable, but we don't really prefer to rotablate previous stents. And regarding the shockwave balloon, because of the pushability of that device, I don't really believe that one could deliver the shockwave balloon. So I feel in the middle of the night, we had to restore somehow the flow in LAD, and I think balloon was, I think, the only applicable option. But I do agree that with that wire position, what I have showed, it was a risky decision to balloon, because I could, before ballooning, I couldn't be sure that that my wire is in the true lumen. But since I wasn't manipulating really aggressively, I had the strong feeling that the wire is in the true lumen. And once the flow is restored in the vessel, we could see that the aneurysm was the reason why I was facing difficulty finding the true lumen. And even after, when I could see where my wire goes, I had a tough time in why Chih-Hung Black could go to the true distal LAD.
Okay, is that satisfied for the your question?
Thank you very much. I think in the middle of the night, I think in the middle of the night, your practice is excellent, because, you know, in China we only have in Beijing we only have like very junior doctors on call for emergency STEMI instead of experts like yourself. So sometimes like rota or like, but because the LED is full of thrombus, I think is unwise to use rota. But excimer laser is quite an optimal option if available. So, but in the middle of the night, excimer laser and all other fancy things are not available to those junior doctors. So I think they will do a lot worse for such a very complex lesion. And also for the second case, if you please refer to the second case.
Yes, I'll go there.
Yeah, thank you.
Do you see what I'm showing? Still?
Yeah, we can see.
Yeah.
Okay.
Yes.
Go on.
I think this case is also very excellently executed, because this case is also, is also heavily calcified, and the RCA, I'm not sure if I'm calling this right, is also a high takeoff or something like that with the origin, or the with a takeoff point of view, not very traditionally positioned. So the position of the guiding catheter is not very, cannot support the subsequent procedures very well. So I noticed you use and also explain why you use JR, Judkins Wright, and use extension catheter to augment the support for the subsequent procedures. Especially for this one, the ostium is heavily calcium and heavily lesion. So my question is this: during this time, I know sometimes it's a lot of more risky to use like AL 0.75, this strong support, this kind of strong supportive guiding catheter for this kind of, but the calcification is quite complex. So should we use so if we would use like SAL for moderate support instead of JR, and should that be more a more safer approach? Because sometimes use Judkins Wright guiding, I experience a lot of time I experience this time for the guiding to push back, counterforce, push back, and the whole system just falls apart, especially in the very complex lesion, especially after inflation, especially after the procedure is midway. So maybe dissection already existed. So I'm just wondering, what is your experience on this kind of lesion? When on one hand you need more support, on the other hand the ostium is quite heavily lesion. So thank you.
If you see the images, thank you very much for the question. Without the contrast, without the dye, you can see that the entire vessel is so heavily calcified. I do agree that short unplugged left would be a reasonable option. What I really like in intervention that, as far as I'm concerned, I think we all can reach an acceptable result on the different roads. But once I was quite confident that the orifice must be stented. In case this orifice of stenting, I prefer the Judkins Wright because I can, I feel more comfortable to deep intubate with the Judkins Wright rather than extra support catheter. But I must admit that I use a lot the short unplugged left, much more than the regular AL1 catheter. But I feel that with the Judkins Wright, you can nicely go to the vessel, and it's relatively atraumatic comparing if you deep intubate the vessel with the extra support unplugged catheter. Although if we must, we have to do it. So this again, it is an acute thing, and the vessel was occluded, so we must do something. But here I feel that the risky part was firstly to cover the orifice, because it will complicate our thing. But I feel that this case it actually helped me, because the position of the guide catheter with this very tight orificial lesion was very unstable, and I didn't dare to leave the orifice without stent if I ballooned it up. So first I wanted to cover the orifice, and then I started to struggle with the mid RCA. And regarding the origin of this RCA, I think it was not the reason of the difficulty. It had a regular orifice. It was not a high takeoff. I think the reason why I had difficulties was rather the tough orificial lesion.
Thank you.
I do appreciate that, the JR, because the coaxial, you ballooning, then you do a guide extension, can dip into a mid portion of the RCA and avoid the dissection and the stenting the RCA also. I think this is the best way to support your subsequent treatment for the distal portion. Because Dr. Zhai is asking regarding the laser, the only experience in Taiwan, I think the VGH Taichung, Dr. Lee. So I like to ask his opinion regarding the first case. That laser is a good choice for the first case.
I go back.
Well, everybody knows that I'm a rotor man, so
you are also the laser man.
Actually, I did relatively few laser cases as compared with the rotor cases, because when we are talking about the international symposium, when we always have difficulty in transmitting the cases, especially live images. Most of the times, the resolution, the gray scales, and the speed are limited. So I cannot make a good judgment based on the transmitted live image qualities. So I'm sorry, I cannot make it a very unbiased comment regarding this very case.
No, just a question regarding the undilatable or the previous under dilatation of the stent. You have a laser partial contrast to expand like a shock wave. What about your hospital experience?
Well, I definitely would choose the OCT guided conscious facilitated excimer laser because especially when the underexpanded segment are relatively long in contrast to very discrete undilatable point. When the underexpanded part is relatively short, we can easily treat it with a blade, the stent strut with a rotor burr, and easily take it fully open. But however, when the underexpanded segment is really long, I think excimer laser would definitely make life much more easier. So my choice would be excimer laser in those cases.
We have one question regarding the shockwave is available in Hungary and the Medicare coverage.
It is not reimbursed, unfortunately, but we do use in some cases. Usually in underexpounded stents we use, but I feel that the pushability of the device is at least at now the weakest. Can I also have one more question? I just tried to grab the opportunity that now I'm just among international experts. Regarding this distal aneurysm, would any of you considered different treatment? Because I'm not really happy that I had to cover that aneurysm with a 2.5 millimeter DES, because it's obvious that the diseased part is much wider than this, that the distal diameter was not bigger than 2.5. So the best I felt I could do is to cover it with 2.5 and just post-dilate it with a 3 millimeter NC balloon, but might be any better option? I'm just want to know your point of view, because I'm not sure that I did the best thing.
I have no comment on the aneurysm. I think nothing much we can do for this. But for the RCA, the one with the jugging rights, personally, I give a little comment on that, because if you use a 7 French jugging, you can put 2 wire into the RCA, so you might have a better support after standing. So you have when you manipulate the ostium, you have more confidence rather than jump off the whole system. That's my.
Yeah, you might be true, but my general practice, I'm working from radio, and usually the European people's radio, sometimes big enough to negotiate 7 French guide, but my workhorse size is 6 French. I really go for femorals, usually for left main. For the right, I prefer to do the 6 French job. You might be true that 7 French, more wires, but even in 6 French, you can go with 3 wires. So it's not
APT braiding rashes is available in CMAC, right? So a radio, in my practice, even the CTO will use the routinely braiding APT, thin fish, no problems, 6 to 7. So same size, and we can use a 7 French.
Yes, completely agree.
Okay, so for time's sake, we have to go proceed. The final question.
Yes, Dr. This Dr. Yi Zhang here speaking. Regarding the question of the aneurysm, I think the aneurysm is not so big. So actually, my opinion is let it alone, and we don't need to treat this aneurysm, because this is not a very big aneurysm. This is my opinion. Thank you.
Okay, thank you for the comment. Okay, the last speaker will be Zhai from Anzhen Hospital. He was introduced that the newer devices, 3.25 guide extension, should be coming soon in China. Hopefully in the future will be in CMAC and available in Taiwan. Okay, Dr. Zhai, please.
Thank you for the introduction. Let me first share my PowerPoint. So can you guys see?
Yes, I can see.
All right, thank you. So,
Mandarin,
so now I'm gonna play it. All right. So thank you for this opportunity to have the very pleasant symposium between our friends from Hungary and also our colleagues from Taiwan. So just before the very flatter introduction, yeah, our hospital achieved like 20,000 PCI last year, and I myself performed 550 around 550 PCIs in Anzhen Hospital, and also about 500 PCIs in all around provinces in mainland China. So, but to just to say a few ideas about the cases we just discussed, because my case is relatively simpler, a lot simpler, just a very straightforward case to illustrate a point. So not so complex like before. But I don't know whether it's right, but in my group, I dictate, I dictate that no Judkins right is allowed to use unless a 7-inch vein graft is intended to engage. For no other kind of guys can engage. So, but for a normal opening right coronary artery, even if the ostium is very heavy, like 99% lesion, I would strongly suggest like ISAL 0.75, because without support, the subsequent procedure can be disastrous. And I've had a few encounters, very bad experience with JR 3.5 or JR 4. So I think a little bit more support and not so much like AL can be both safe and also efficient in facilitating the subsequent procedure. I don't know whether it's right. And also for the other case, the LAD thrombus combined with calcification, we know Rota can deal with calcification. Shockwave, I've only had 2 cases because it's still experimental before it's coming to commercialized use in mainland China. I only have 2 cases, but the crossability is so terrible that I can't imagine crossing over any significantly calcified lesion unless the unless a cutting balloon is also very fluently, very crossable in this lesion. So I think that would greatly limit the clinical use of the shockwave balloons. So I would strongly recommend in this scenario to use excimer laser. I've conducted like around 100 cases last year of laser. So I rank #1 in the laser use in mainland China. So I would very much recommend laser for this use because thrombus is contraindicated for Rota, but is highly indicated in for laser. Sometimes when we in the STEMI scenario, in emergency scenario, we can't really restore the TIMI3 flow. We inflate, we also aspirate. Nothing can restore, but maybe PDCA, maybe other thrombolytics. So laser can be a miracle worker because sometimes with a 1.4 or even 1.7 millimeter laser, we do several rounds, several laps, like 4 or 5 or 6. The TIMI flow, so the TIMI flow 3 would restore perfectly. So laser can be a very effective tool to dealing with thrombus. And also calcification, when combined with thrombus, Rota is contraindicated. So this time, in this scenario, thrombus and rock and thrombus, I think laser is very well placed into this scenario because it can both deal with rock and can deal with thrombus. So that's just another comment I just want to get on my chest. So as for my title, I named it 不入虎穴焉得虎子 because it's a tiger year in China, right? So in lunar tiger year. So just to translate it, on the internet, the standard translation for this proverb, this Chinese proverb is nothing gain. Nothing venture, nothing gain, right? So, but it's not what I mean. I want to mean literally just, you got to go deep into the tiger's cave if you want to capture the cubs. So you want to go deep into the tiger's cave. Apparently, I want to say you can use a 3.2F French extension catheter to go way more deeper into the lesion, to go near the lesion. So you can achieve better support. So this is my case, a case of 3.2 French extension catheter assisted RCA CTL recanalization with a high takeoff variant of RCA. So this is my case. My case is a middle-aged male with some risk factors like hypercholesterolemia, hypertension, and also have unstable angina and heart contraction function. Yeah, ejection fraction is okay. So let's see the angiogram. Angiogram can show the right coronary artery is high takeoff, so the support is a major concern for my PCI, and also the CTO, the occlusion segment is not very long, so it seems a very simple task. So at first I didn't want to do bilateral angio, but also but later I still do that because this is not a very simple task at all. So I use first a 6 French, but later I exchange to 7 French, another with the APT sheets. With the APT radio sheets, we can achieve 7 French guiding catheters routinely in our practice. So we use 7 French on plus 0.75 to engage in the right coronary artery, the high takeoff, all stem, and also we use Cyan Blue. Cyan Blue is a relatively very efficient, very manipulatable, and also have very good support. So we use this to help guide our extension guide catheter and also our micro catheter to near proximal to the lesion. So we want to when the guiding catheter due to the high takeoff RCA cannot support very well, we use Expressman and also the instant path to give the double support to the wire. But Cyan Blue apparently cannot go into the micro channel, so we escalate into the filter XTA. Filter XTA is very well suited in this scenario to track into the micro channel. Apparently, this case, the conclusion is not very hard for the wire to cross. So the wire crossing is actually very simple. The whole procedure for the wire cross is like 2 minutes or 3 minutes. So after the very double support for the wire, we advance the 1.7 French instant pass micro catheter because this is by far, as of yet, the most thin one in profile to advance for the wire exchange. So we exchange for the Cyan Blue without any difficulty or obstacle, but our nightmare begins now. For the double support, the wire advancement is quite easy, but the 1.25 Tizuna balloon cannot pass because our support is very poor, and we use 3. We also use a 5 French extension guiding catheter, extension catheter to help advance the Tizuna, but also fail. So after several attempts to limit our operation time, I use a 0.9 millimeter excimer laser with a sitting technology. Sitting technology means we don't have to use a sitting flush. We just sit the excimer laser to the proximal capsule, to the proximal lesion, and we just do 80 hertz, 80 energy to maximize its neutralizing energy for only 3 seconds to avoid any perforation. So after like 2 or 3 attempts, our 2.0 balloon cross easily without any efforts. So we do inflation and also stenting. This is the final result. So the whole procedure time is only 50 minutes. So this is a very simple task with a little obstacle. Both obstacles is due to the poor support of the guiding catheter because of the right takeoff. So we want to say for the little calcification, very little calcification to obstacle my balloon advancement, I use excimer laser without exchange for like rotor wire. So it's very easy and very efficient. The whole laser procedure costs like 5 minutes to help my balloon to advance. And for the first obstacle is how to proceed my wire without proper support. So double support, both the guiding catheter, also the 3.2 French extension catheter to advance very hard, very further, like going to the tiger's cave. So help my case to complete. This is my very little case, very simple case. So thanks for your attention. Thank you.
Okay, very interesting case and also challenging. I guess my question is how much for each laser procedure, because the medical reimbursement should not be included. How much for Beijing?
Excellent question. So, mainland China is actually going through a very, very not excessive, very complete revolution in these reimbursement. Also, the prices of our equipment. So now, for average stents is only cost like 300 to 500 yuan. I don't know how to translate that into, other kind of currency. So, yeah, it's quite cheap actually. So, we do a lot of other equipment. We are very careful to not tread any red line. So excimer laser is quite expensive, around 35,000 yuan. And in some parts of China, mainland China, like Beijing, Shanghai, the excimer laser is covered like 80 to 90%, but not in all of the mainland China. So in Beijing, we can do this procedure very freely without considering the cost, because it's actually quite quite expensive. But sometimes it can work a miracle like this one. If I do, I use I advance the 1.7 microcatheter. I'm very confident it can go through. And after it goes through, I can extend for the rota wire and do rota. And I'm sure the rota will be very easy too, because the calcification is very limited and not very strong. It just need a little tap on the calcification. But with laser, with a more investment, with more cost, it cost me only 5 minutes. So I think it's a fair trade. Thank you for the question.
There's any comment from, especially Dr. Lee, only available laser in Taiwan? Okay.
Well, the machine, the laser machine is not available in every places in Taiwan. So it was only limited. I know Taipei veteran has his own machine.
Maybe Dr. Lu can comment later.
Okay. I'll pass the microphone to him.
Dr. Lu?
Yes, yes, we have the laser machine, but it was not used for many years. At first, it was prepared for the peripheral intervention, but of course, the cost is one problem, and actually our experience is very limited. Especially for the, I think, calcified lesion or organized thrombus is very useful.
But I guess I agree with Dr. Zhai's comment regarding that 014 wire can pass. Then you don't need to exchange any microcatheter. Then you can just go laser. But only comment regarding the angulation. Is any tip and tricks? You select the size of your laser. Is any comment?
So the vessel size is actually quite small. You might notice I didn't do any like OCT or IVUS to confirm whether my stent is quite expanded or opposed, because the vessel size is actually quite small. So I don't want to use any further, like OCT. I'm not sure that maybe the distal part of the vessel might be occluded by the OCT tip. So I think with a proper post dilation, maybe the stent is actually is okay. It's optimal ready. So, but as for the laser size, I've had like 100 laser a year with only one perforation. The perforation is not because of other reasons, but the small vessel size. So with this small vessel size, I'm very careful to firstly limit the laser selection to 0.9 millimeters, the smallest size, and also the contact time is quite limited, unlike any routine procedure. Routine procedure is saline flush and very little speed, like 0.5 to 1 millimeters per second. But with this case, my laser tip is not moved at all. It just sits at the proximal cap, and just for 3 seconds, I zap him, or like I laser the lesion, and for 3 seconds, I just run away before any significant damage can be caused, because no saline at all. And also for this procedure, I like to call that sitting technique, because sitting technique is actually a name coined by myself. So like sitting is actually not very elegant, because sitting, other people might relate to the position when you go to the toilet. Sitting technique. You sit there for a while, you do your business, and you walk away. So
this is the kind of mechanism you're breaking that proximal cap.
Yes,
is that
yes,
right?
yes. So only 3 seconds to avoid any perforation. So this can cause enough destructive power to the caps, to the proximal cap for any further subsequent balloon crossing. Thank you.
I guess any comment or not, because time limits, we have to wrap up because already 9 p.m. But I guess we do enjoy each speaker's presentation and very wonderful discussion. And also we'd like to thank you for the APT International part to support this kind of virtual meeting, including Taiwan and also Beijing, also in Hungary. So hope everybody enjoy it, and we can experience more with the tapered tip expressmans. Okay, thank you. I have to wrap up here.
Thank you very much.
Thank you.
Bye. Thank you very much.
Thank you.
Bye-bye.
Bye-bye.
Bye bye.